Hi, I'm Dr. David Gross, psychiatrist,
And I'm Dr. Andrew Rosen, psychologist.
and we are two shrinks and a mic. Well, we're going to continue our discussion about the nature of the landscape of mental health care, because it's really, I think, the way we can be of most help to our audience who are trying to maneuver their way through the minefield sometimes of mental health care, because it can be confusing. We've talked about, the nature of therapists and psychiatrists and psychologists and master's level therapists as well, but it's also important to talk about how do you know that you're with the right person? How do you figure that out? I mean, oftentimes you can tell that you're with the right family doctor or primary care practitioner because they take what you're saying seriously and they send you for the tests you need to go for, and they prescribe the right medication and give you an antibiotic when you've got an upper respiratory infection that needs one. But I think it's much harder with mental health professionals because, as we said before, the whole field of mental health is a bit amorphous. I mean, it's a bit more difficult to define it. You can't use the same kind of criteria that you'd use for an internist, where you can check to see where they're trained, and you know for sure that if they're trained at a certified American residency program, that they meet the same criteria in most of the programs around the country. But in mental health, it's tougher. And how do you determine between a psychologist and a master's level therapist who's either a social worker or a marriage or family therapist or a mental health counselor versus a psychologist? And if you determine you want to see a psychologist, how do you determine between a PhD psychologist and a PsyD? And psychiatrists, the same issue is there, because the training is about the same for the most part, but their experiences and what they bring to the experiences, what they bring to their career, to their own career and their practice, can be different. So that opens up a whole bag of worms that I'll let you take from there, Dr. Rosen.
Okay, here come the worms. One of the things that came up just the other day, actually, Dave, you sent me an article that was, I think, in the Wall Street Journal or the New York Times, and it was about how today, in today's times, many clinicians, many therapists are taking the focus off the individual and whatever their particular problems are and their history and their situation, and kind of transferring it over to more of a social issue, and in terms of the times that we live in. And many patients, whatever their issue might be, if it's a woman, tends to be the problem is because of the way men are. And if it's a man in treatment, it's because of some difficulty he must be having getting out of the male stereotype and maybe being less of a man and more into being, having a feminine side. But the whole thing is it's trying to fit the particular problem of the individual into more of a social context. And many times, regardless of what the individual the individual's problems are, the focus tends to be on trying to maybe deal with or prove that the world we live in today or the social climate we're in is the cause and the problem. Now, we all talk about this methodology that we approach with, and that is the biopsychosocial model, which does take into account the social aspects of a person's problems. But one of the things that we've seen more and more is that many clinicians have an axe to grind, and they take that axe and apply it to the situation. So what also has an impact on this is when you're looking for a clinician, and very often now it's on websites, you'll look for a person, let's say, who treats anxiety, and then you'll look and see their credentials, and they say they specialize in anxiety, but they also specialize in 20 other things. My belief is, and I think yours, David, as well, is what you want to find is somebody who really specializes in a particular problem, and because they'll know that problem better. But maybe avoid the person who is specializing in a particular method. And that is because very often a person will apply the method to the problem and to the person, regardless of whether or not that particular problem is most beneficial being treated by that particular orientation. So look for somebody who has a specialty, doesn't have an axe to grind, and doesn't necessarily only treat with one method.
You know, I thought that article was excellent. It was the New York Times, but I found myself wondering after reading it why it was that there is that kind of change in focus. And then I realized, we talked about this in the last podcast, that a lot of people bring their own issues who are therapists or psychiatrists into the consulting room.
Mm-hmm.
And behind the trying to deal with a person's individual problems and then trying to put it into a cluster of social issues and societal issues, my sense was that there was a lot of frustration, anger, maybe even burnout. And so that's important to take into account. But the other issue about finding a clinician who really is specialized in that area, you can take, for example, trauma, psychological trauma. Most therapists will say, or psychiatrists will say that they treat trauma. But how many of the therapists are specialized in treating trauma? For example, how many have had a formal course on EMDR, which is one of the treatments that could be most effective for trauma? Or an individual who is treating individuals with maladaptive personality traits and states that, yeah, I do DBT, dialectical behavior therapy. I took a weekend course. It's not the same, and that's part of the problem. But we have a field that is a little bit loosey-goosey in those areas because of the lack of rigidity over qualifications. In our state of Florida, in the 1960s and early 70s, the only thing you had to prove to the licensure department in the state of Florida to become a therapist is to have a diploma from a school. Doesn't have to be a training school. So one of the psychiatrists in Gainesville where I trained had a diploma from his grade school on the wall. It's that kind of change that's been problematic, and it's also important, I think, to if you're meeting with a therapist or a psychiatrist and you feel like there's something missing, to pay attention to that, and sit with yourself or talk with people who you trust and try to figure out what it is that's not right.
There's an old concept in psychotherapy that deals with something called transference and countertransference. And transference is what a patient might bring into the treatment in terms of their experiences with other people in their lives. Countertransference relates to the therapist having issues or problems that they will then sometimes inadvertently apply to the patient. So, for instance, not that this might happen typically, but let's say the particular therapist has just gone through a really tough divorce. And then a couple comes in or an individual comes in and is having marital problems. The question is, how skilled is that therapist at not letting whatever issues or residue of his own divorce be applied to this particular relationship issue? And there's so many examples like that where, the therapist is a human being, and their ability to separate out, to be aware of, but also partial out their gut feelings and their own histories and their own problems from letting it come into the treatment room and then be worked out on that patient. So it's very important for any patient to be aware of, is my therapist somehow injecting his own issues and problems and belief systems into my situation? Or is he being able to be very objective and neutral? That's a big one.
When you think about the training involved in becoming a therapist, whether you're a psychiatrist that does psychotherapy or master's level or doctoral level, the training involves learning more about yourself. Mm-hmm. And the book learning is the same as we've talked about before, but it's not just book learning alone. A good bit of the training for becoming a psychotherapist is to be supervised by experienced therapists and knowledgeable therapists who can give you feedback about yourself and help you identify where there is countertransference, and we all have it. and it's important to acknowledge that it exists. Realizing that you have it is really the challenge, because then you can begin to recognize I cannot let my own reactions to this story or this individual color my own comments and my own guidance in the process. And if you think about that concept of transference that you raised, you're really trying to get the patient, the client, to transfer their own issues onto you as a figure, so that you can help them interpret what they've been doing to you. And the only way to do that successfully is to recognize your own psychological makeup and how you can be that kind of blank screen to allow the transference to occur. So it's really important to get a sense that of the therapist, that when you're sitting with them, that they're going to be listening well and taking in the information and not immediately stepping in with judgmental issues and comments, but they need to be able to process it for you, and then give you feedback that's helpful.
One of the areas that has become kind of a hot subject, even in the therapy situation, is, and we've been reading about it in the media as well, is families breaking apart and people not being able to talk to each other because they're on the opposite sides of political issues. But that also comes into play in the therapy situation. So what happens if you have a therapist who's on one orientation side of the spectrum and then the patient's at another side? How does that get worked out in the therapy, both overtly and even in subtle ways? So one of my pet peeves about our profession in general is I'm a firm believer that if you're going to be providing therapy, you should have had your own, or some semblance of it, even it's a short course of therapy. In my own training, because I also trained as an analyst, I had to have 4 years, a few times a week. I'm not saying that's necessary for everybody, but there should be some time where a clinician, I believe, takes time out to take a look at what it's like to be on the other side of the couch or the treatment room, and to at least to highlight their own issues that might play a role.
One of the core components of the interaction in the consulting room is the concept of unconditional acceptance. Easier said than done. I mean, let's say that you're a Democrat and you can't stand the Republican Party and Republicans are doing, or vice versa. You can't let that sway your thinking if somebody comes into your office and they start talking about all their Republican principles, or or a Democrat that comes in to talk about it. So being able to provide that unconditional acceptance requires you to recognize how you feel internally when somebody comes into the office with something that's different than you're used to and something that makes you uncomfortable. You have to be able to learn how to let that roll off your back and be able to proceed in providing a decent, well-rounded caring. Individuals I've seen who have life situations that I can't say that I'm particularly in favor of. If I come into that session and begin to be critical of it, I'm no different than their parent, and that's not helpful at all.
What do you do as a clinician if you are one of these people who never talk to their family members? Let's say they haven't spoken to their mother in 20 years. How do you help that patient who comes in and is struggling with the relationship with their mother? These are just, I could go on and on. We both could about these kinds of scenarios,
but you can't blame it on the mother.
Yeah. It's tough work, and it's a tough situation to be, as objective as possible. So for the patient, our urging would be look for somebody who's got a lot of good training and does have a specialization. And when you meet with that person, you get a good feel in terms of what you just described as, unconditional regard and willingness to look at things, from different points of view and as objective as possible.
We've talked before, the initial interaction with a mental health clinician is to be able to provide them with a history. And the clinician needs to listen well and also to ask questions to try to get more information out. And how they ask those questions, I think, make a big difference. That besides this, did you also experience that? Or I'm sure being raised by a parent who treated you that way, or having that kind of traumatic experience in childhood had an impact upon you. And so there are questions you can throw out there that help elicit more information. But gathering all that data is absolutely critical. So it needs time, and it requires that the clinician you're meeting with, the therapist or the psychiatrist, is open to gathering all that data before coming to a conclusion. And we've talked before about how some people jump to conclusions too quickly and end up going in the wrong direction in terms of treatment. But once all that data is gathered, then it's very reasonable for the individual who's seeking help to get a clear picture as to what the clinician thinks is wrong, whether they be diagnoses or patterns of behavior or behavior or past experiences that are negatively impacting upon their lives now, but to get an idea of what's wrong. And after you get an idea of what's wrong, the next step is, what kind of treatment do we need to proceed with, and what would be the goals of treatment? Individuals who have been anxious and scared and obsessive and having panic attacks for the past 15 years, they're not going to get better right away. And you need to hear that. You need to hear that it's a process, that it's not going to be a quick fix. And in my profession as a psychiatrist, I have to tell people that no pill is a magic bullet. That you may need a pill and you may need a form of psychotherapy, and you need to do both oftentimes. But to really specifically ask about what's the nature of the treatment, what are the goals we want to reach, and how do we proceed is very, very important. I've been impressed with therapists in the community who will say, after I've gotten all this information, you really need help from somebody who specializes in this particular area of treatment, and it's not something that's in my ballpark. And that's somebody who's being a very honest, open, and caring clinician. All too often, and I'm sure you've had the same experience, therapists will take on problems that are beyond their scope of experience and training. And it's oftentimes a mistake, but the field is a competitive field, and there's lots of difficulties in trying to get individuals into their office and stay busy. And so that allows clinicians to take on cases that they really shouldn't be taking on.
So one of the things that, as a patient, I think is important to understand when they come to therapy or they come in for treatment is, should I have any expectations in terms of time frames? It's clear that almost no problem is going to be fixed overnight, and medication isn't the magic bullet, and so on and so forth. But there's got to be some degree of ability to kind of know, when should I start thinking about maybe this isn't helping me by now? Is it a month? Is it 3 months? Is it 6 months? Is it 9 months? And one of the things that I think we both have the ability to do is when somebody comes in and we've seen them once or twice, we get a sense as to how severe the problem is and the depth of it, and we can pretty much predict. Are we looking at a kind of to get some degree of improvement where the person feels like, I don't feel as bad right now? Is that going to be like a 2-month thing? Is that going to be a 3-month or a 6-month? Are we talking about this is going to be a major overhaul of issues and it could take a year or two? We have the ability to give some estimates on that, and I think it's important for patients to hear that estimate. It doesn't mean necessarily that we're going to be held down to it, but we should be able to give some time frame so that people walk out of that office the first or second time having some idea of how long I'm going to do this for, and what's reasonable to think in terms of a prediction for some degree of recovery. And I think most people, especially people who specialize in a particular problem, can give that. Not to the day, but sometimes I jokingly say when somebody says, when am I going to feel better? And I'll say, well, let me look at my watch. They know I'm kidding about that, but we can come up with some rough estimate. So I can say, look, I think, and we have data to support it, like for treatment of panic disorder and other anxiety disorders, we can see significant improvement in 12 to 20 weeks. So we know, okay, we're looking at 3 months, 4 months, 5 months. You should be really significantly feeling better. And that's with or without medicine. We have time frames available.
And, because we treat a lot of individuals with anxiety disorders, oftentimes it becomes a multi-step process. It's helpful for people to recognize that there may be stage 1, stage 2, and stage 3. So, for example, if somebody who's experienced a number of significant traumatic life events, and as a consequence of that has developed panic attacks, we'll tell the individual we first need to help calm down the panic before we can do anything else. And so stage 1 is going to involve sometimes medication and certainly a certain amount of cognitive behavioral therapy and mindfulness and meditation and relaxation techniques to get a handle on the panic attacks. But the panic attacks are just the tip of the iceberg. The next step really is to identify the nature of the trauma and then to put together a plan of action to begin to help the individual get rid of some of the long-lasting effects of life trauma. And then in that individual, for example, there may be some need to do some marital therapy since the spouse has had a hard time understanding what's going on with their spouse and the panic attacks. And if you haven't had a trauma experience in your life, it's hard to understand what it's like to be traumatized like that. And so then a certain amount of education and family or couples therapy will need to be done. So viewing it from the perspective of a number of steps is often helpful and helps the individual who comes for treatment to recognize that, well, we've got to work on this. It's not going to be overnight, and it's a reasonable process to proceed with.
It's just really important for all patients to have some sense of how long will this take, and so they don't step into this dark abyss and hope that somewhere in the next decade, I'll feel better and I can leave. We do have the ability to be much more definite about that. And again, that's going to be based on the level of experience and training of the clinician. And if you don't get that sense, if you're walking out of there the first few weeks or even month and feeling like, I don't know what's going on, I don't know what the goals are, I don't know how long this is going to take, you might be in the wrong place.
In psychiatry, one of the problems has been that with medications, psychiatrists will often find their favorite medicine, and they try to apply it to all problems, and that's a real mistake. And some of it comes from, uneasiness in the field because of the fact that we don't have the same kind of science base that other areas of medicine have. But, there are psychiatrists who will take their favorite pill and apply it to not just anxiety problems, but all sorts of different problems, and that can create difficulties. And so the approach I take is to say this is a medication I think can be of help, and let me tell you why, and that we need to balance the benefits against the side effects so that this is a medicine that you can stay on and without having difficulties, and tell people that it needs time to work and you have to be patient with it, et cetera. But the education, as we've talked before, is a significant, important part of anything both of us do. I'm sure you explain to people the purpose of psychotherapies and why it works, and I do the same thing with medications.
And it will also explain the synchronicity of the two. It's most people don't know much about what goes on in the field of mental health treatment, and maybe less today, maybe more people are a little bit more savvy, but it's really like stepping into an unknown territory. So it's very important, even just to reduce some of their anxiety, to get them to understand, here's what we do, here's how we look for things, this is what we should expect, and if you have questions and you're not sure, we need to talk about it. Very important to be collaborative. I talk to all my patients about this as a collaborative effort. And so, the kinds of things we're talking about today and over the last few times we've done the podcast are meant to clue people in as to what to look for, and if they're not getting it, to raise a question about, am I in the right place? And to talk about it with that clinician. If they don't get a good answer or they're not getting a good response back in terms of listening and willing to talk about it, then I would say you're definitely in the wrong place.
The collaborative notion you raise is a very important one because I view the interaction between the clinician and the patient or the client as a true team approach. Mm-hmm. There's so much power that the clinician has, whether it be a therapist or psychiatrist, that oftentimes the patient will be passive and allow the clinician to do whatever they think is necessary. And it shouldn't be that way. They should be more of a, we're doing this together, and I need to hear from you if you have concerns and questions. And if you're worried about medicines and you're fearful that it's going to change your personality or be addicting or some medicine that you'll never get off of, you need to tell me about it. And welcoming them into this kind of collaborative team approach is terribly, terribly important. And some of that is influenced by the time pressure with insurance reimbursement and clinicians who see patients as insurance providers. They often have to see a very large volume, and that can decrease the amount of time that they can spend with the individual, and that often leads to quick decisions about treatments without really engaging the patient as a member of the team, and I think that's absolutely critical.
So these are just some of the things that we feel are important for people to know about, and not only in terms of deciding when to go to therapy, but who I should see, what should I look for, and what are some of the things that I should not expect to see, and what to do if that happens. I mean, it's very easy to decide at some point, look, this isn't working for me. I think I should have been feeling better by now, and just to go on and on, I don't think that would be what's good for me. So that's when you look around for or ask around for somebody that might be more suitable for your particular problems, and don't hesitate to do that.
And be assertive. You have to be your own advocate. It's tough when a person's got terrible depression, terrible anxiety, or marital stresses that are at a peak. It's very hard to say, look, I need to do this for myself, and I need to ask the questions and be my own advocate. But it's very important to be assertive and don't shy away from it.
So if anybody has any further questions about this topic, I mean, you can definitely send an email in, and we'd be glad to answer any of it. But I think we've kind of, over the last 3 podcasts, dealt with a lot of the details about how to choose people to help you. And now I think what we'll do in the next few podcasts is talk about specific problems and disorders that we've not touched on so far, and including trauma. That would be one, and some of the other issues that we face every day. So for both of us, this has been a really good thing for us to be able to talk to you about this. And I'm Dr. Andrew Rosen, psychologist.
And I'm Dr. David Gross, psychiatrist, and we are 2 shrinks and a mic.
The 2 Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.